Okay, we're good, Kirsten?
Yes, we are. Thank you.
Okay, Secretary, we are live.
Oh, wonderful. Now I'll call the meeting to order and ask you to do the roll call, please.
My pleasure. Good morning, everyone.
morning.
Rebecca,
Present.
Michael,
Present.
Eric,
Present.
Martha. I know you're there. I'll come back. Dimitri. Okay, Secretary,
Here.
Nancy.
Morning, Kathy, I'm here.
Morning, Matt,
I'm here.
Rena,
I'm here.
and I'll do one more call for Martha. We know she's there.
Hi, I'm here. Thank you.
Okay, thank you. That's everyone. Thank you.
Wonderful. Thank you. Now, the first item on the agenda is to entertain approval of the minutes of June 8th. I'll entertain a motion. I'll move it.
So moved.
Second.
And Kathy, we need another roll call on the minutes.
Okay, ready. Rebecca,
Yes.
Michael.
I think I need to abstain. I was absent for the last meeting.
Okay, Eric,
Yes.
Martha,
Yes.
Secretary,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes.
Thank you, everyone.
We're doing great, team. This is wonderful. Okay, thanks, Kathy. You can take a breath now. The next item on the agenda is the Executive Director's Report, and Audrey will lead us off.
Great. Thank you so much, Secretary. Good morning and welcome to today's meeting. The July board meeting typically includes a very full agenda, and today certainly fits that bill. The MassHealth redetermination process and our work enrolling new members remains our top priority. We continue to see our operations run relatively smoothly and have already enrolled more than 16,000 people into Health Connector coverage, slightly ahead of forecast. We anticipate August 1st enrollments will be the first month with more than 10,000 newly eligible people from MassHealth enrolling. We are still relatively early on in the process and haven't yet seen the real steep increase in newly eligible people who are reaching their termination date with MassHealth, but we anticipate those more substantial waves are coming soon, and we spend each day making sure we are as prepared as possible. We continue to go all out with high visibility outreach, community-based enrollment activities, and messages blanketing the airwaves. We are dialed up to 10 on our full array of direct communications, including outbound calls to people losing MassHealth and gaining Health Connector coverage eligibility. Our full court press on raising public awareness includes a press event this afternoon in Worcester with Lieutenant Governor Kim Driscoll, and we are looking forward to discussing redeterminations with the Lieutenant Governor today and promoting our enrollment event at Worcester's Polar Park next Sunday, July 23rd. Today's presentation on redeterminations will include an update from Elizabeth LaMontagne, the Chief Operating Officer at MassHealth. We have been working extremely closely with Elizabeth and the MassHealth leadership team throughout this process, as well as the team at Healthcare for All, and appreciate Elizabeth taking the time to share details with the board today on MassHealth's work so far. Connector staff will follow Elizabeth for the full array of Connector-specific updates. Today's agenda also includes an important milestone in our 2024 seal of approval, as we detail the responses we received from the market during the carrier seal of approval submission process. In addition to a readout on the core product shelf proposals from carriers, you'll hear about how the 2024 seal of approval continues to expand our work to promote health equity in new ways. This includes requiring health and dental carriers to conduct a multilingual outreach campaign, particularly reaching Connector Care members, aimed at reversing troubling trends of foregone preventive services, especially among the lowest income enrollees we serve, and to encourage members to receive physicals and screenings that they are entitled to at $0 and can, of course, save lives. We are also taking a significant step forward in our equity space in 2024 by including all carriers in Connector Care. The first step in a 2-year process we included as a new requirement that we announced last year in our 2023 seal of approval. This will be the first time in our 17-year history that our marketplace will deliver access to the same array of carriers and provider networks to every single enrollee, regardless of their income or subsidy eligibility status. In addition to making our marketplace more fair and equitable, this will shore up areas of the state where Connector Care enrollees sometimes have had only 1 or 2 carrier choices, and the program was at times vulnerable to shifts in carrier business strategies. In the immediate term, we are also continuing to keep an eye on the state budget process, which may include a pilot program expanding eligibility levels for Connector Care to allow more individuals and families to qualify, which had been proposed as part of the House FY24 budget. If the final budget does include any expansion pilot program and is signed into law, we will need to immediately pivot to implementation, which would include system updates, seal of approval amendments, and regulatory adjustments. We will certainly keep you updated on this and outline our needs as we potentially move forward. Today's meeting also includes our annual budget update and review. So Carrie will walk the board through the budget recommendation that was presented at this board's A&F subcommittee meeting on June 27th, where the subcommittee members reviewed and agreed with staff recommendations. The current fiscal year 23 projections reflect a favorable balance of $11 million, much of that due to the MassHealth redetermination process starting later than anticipated. The FY24 budget includes an array of additional one-time funding for supporting the historic redetermination enrollment process, particularly around contact center capacity, billing, enrollment, mailing costs, outreach, and public education. It also reflects sizable anticipated enrollment growth across the connectors lines of business, but especially in connector care. Our last item today includes a request for your final approval of proposed amendments to our minimum creditable coverage regulations, which we detailed for you at our May board meeting. We conducted a public comment period and held a public hearing on those regulations last month, which generated 2 supportive public comments, one from Healthcare for All and one from Blue Cross Blue Shield of Massachusetts. Today, we'll ask for your vote to approve the amendments as proposed. I do want to note also in the regulatory sphere that last Friday, the Biden administration proposed long-awaited new rules on short-term limited duration plans and other plans that often fail to deliver full benefits and consumer protections to enrollees. Massachusetts has had existing insurance market rules that had fortunately prevented the weakened 2018 federal rules around these kinds of plans from having an especially negative impact here. However, increased protections are essential to ensure residents do not end up in skimpy coverage without ACA protections, especially as we continue through the MassHealth redetermination process and more people are looking to access coverage. Strengthened standards at the national level have always helped us keep people in the right kind of coverage here in Massachusetts, and they discourage the kinds of national actors that try to market weaker coverage, even in places like Massachusetts. As always, there is so much vital work going on, and we should move into the agenda. Thank you to the Health Connector staff for their tireless work to keep people in the state covered and their commitment to making sure that coverage is comprehensive, affordable, and fair. Thank you as always to this board for your support and your insight, and we're looking forward to today's discussion. So hand back to you, Secretary.
Well, thank you, Audrey, and thanks for that summary. We do have a lot, but are there any questions for Audrey before we get started? Okay, hearing none, we're going to march right in because the next item is really timely and really important for all of us. It's an update to the MassHealth redetermination and enrollment transitions effort, and it will be led by Marissa Bolterman, Patricia Grant, Jason Lefferts, and the new MassHealth Chief Operating Officer, Elizabeth LaMontagne, and I think Marissa is going to kick this off for us.
That's right. Good morning. Thank you, Secretary. Advance our slides. Great. So we're back before you this morning to share updates on the MassHealth redetermination process, and we're very pleased to be joined again today by Elizabeth for an update from the MassHealth perspective, and we'll also review our membership trends, outreach, and call center performance. So with that, I'll hand it right over to Elizabeth.
Thanks so much, Marissa. So as you all know, the redeterminations process began on April 1st. And now that we're 3 months in, we've really focused on ramping up to make sure our systems and processes are working as expected. Throughout this process, we remain committed to 3 core goals. The first, making sure we're preventing administrative loss of coverage as much as possible, particularly for members who are most vulnerable. Making sure members know what actions they need to take and have the resources in their community they need to support taking those actions, and making sure we maintain compliance with federal and state requirements. Through the first 3 months, we're happy to share that our outreach and member engagement efforts are in full swing. We'll talk a little bit more about that in a bit. And since April 1st through the end of June, we've initiated renewals or redeterminations for about 331,000 members on MassHealth. This really represents that measured ramp up I was talking about. And as a result, because we've been really slowly ramping up in the fact that members have 45 days to respond, we haven't seen much change in our caseload yet, but we do anticipate that will change as the summer continues. Thank you. To dive a little bit deeper into the outreach, Through the end of June, our partnership with Healthcare for All has really taken full force. So they've knocked on over 320,000 doors, and community-based organizations through this partnership have held over 500 events in the 15 communities in Massachusetts, where the most members are at risk of coverage lost. We've also been hosting several in-person renewal events focused on specific member populations, such as those who are experiencing homelessness. We're also making sure, in addition to this broader community engagement, that we're focused on direct member outreach at the time an individual is selected for renewal. So we send text, email, and automated calls to tell members to be on the lookout for that blue envelope and to make sure that they reply by the due date. Our accountable care organizations, ACOs, and health plans are conducting member outreach to make sure that members know they're selected for renewal and know what actions they need to take. And we're also sharing data with other state agencies that we have a shared client base with to make sure that they have the information they need to outreach members that we share. This includes agencies like the Executive Office of Elder Affairs, as well as the Department of Mental Health. In terms of our performance to date, our systems, our contact centers are operating as effective. This ramp up's really allowed us to make sure things are working as anticipated and allow us to prepare for when we anticipate a higher volume later in the summer. We've also launched our monthly public dashboard, which will provide key metrics and allow folks to see how our caseload is changing throughout this process. Right now, if you go on mass.gov/MassHealthRenew, you can see the June dashboard, which includes data through the end of May. And then later this month, we'll launch the July dashboard, which will include data through the end of June. I'll share a little bit about some of the functionality of this dashboard. Marissa, if you want to flip to the next slide. Thank you. So there are a couple different views here that we hope will really allow folks to understand how our caseload is changing and provide transparency into how this process is going. So this first view allows you to see the active caseload of MassHealth for the current month across the state. The heat map shows where our population is concentrated, and along the right, there are filters that allow you to look at specific subsets of our population, filtering either by age group, whether they're in one of those top 15 communities, or in their disability status as well. You can also see the monthly change. As you can see, we're largely staying constant at 2.4 million members for now. But again, we anticipate that change later in the summer. Along the top, there's these buttons that allow you to look at the similar view, but showing only members who have newly joined MassHealth. And then all the way to the right, if you were to select that departures button, you would see members who are leaving MassHealth coverage and have that same ability to filter and look on the heat map. Flipping to the next slide, you can see the second view of the dashboard. This only shows 2 months right now, so it's not as helpful or as informative as it will be as this process continues. But what you can really see here is how our caseload is changing over time. So this top graph will show in the blue bar the MassHealth caseload month by month, and then the orange bar is the Health Connector caseload month by month. What we anticipate happening through this process, as MassHealth's caseload decreases, we anticipate seeing that Health Connector caseload increase. That black bar across the line that you also see is the caseload for MassHealth as of February 2020, so prior to these federal maintenance of effort provisions going into place. We think that's a helpful baseline to understand where our caseload was before and understand that trend in our caseload in comparison. The bottom graph just shows members who are reopening every month. When we say a member reopens, we mean a member who previously was on MassHealth in the last year, departed coverage, and then came back onto the caseload. This is a helpful metric to track when we think about the process of redeterminations and whether members are able to really get that first bite at the apple when we send their renewal, or if they're losing coverage and coming back on. The final view right now, again, not as intuitive in the first month, but Marissa, if you flip slide to that one, thank you. Across the top, you can just see the number of members that are selected for renewal by month. I know right now it looks like we selected fewer members in May than April. That is not the case. Our systems select by the household level. So we selected more households in May. They just happen to have fewer members per household in that month, which is why it looks like a ramp down, but we are ramping up applications and households selected. And then the bottom graph just shows new members by month. Again, this is data through the end of May. We'll have the dashboard refreshed later this month with data through the end of June as well. But this is available online and is a great resource to understand changes and trends in caseload. If you flip to the next slide, at MassHealth, we're recognizing we're 3 months in, but as I mentioned, we haven't really seen that significant change in our caseload yet. As we look to what will happen in Massachusetts in summer and early fall, we're also looking at national data and trends that we're seeing, particularly from states that began earlier than Massachusetts. And what we're seeing in those states is they really are facing challenges in having members respond and keep coverage, and as a result are seeing really significant reductions in caseload. We expect to see significant reductions in caseload beginning in July and August because some members will no longer be eligible for MassHealth, or because they're not responding to their renewal and will hit that termination point where if they do not respond, they lose their coverage. The reason this reduction is happening a little bit later in the summer, there's a few of them. The first is that we really did that slow ramp up in April and May, allowing us to scale up and make sure our systems and processes are working effectively. The second is that members have a significant amount of time to reply, 45 days. And even if they do not reply, they have an additional 14 days before they lose coverage when we notify them. And third of all, we're really focused on making sure that members have as many opportunities to renew as possible, and particularly really focused on making sure our auto renewal rate is as high as it can be. So we recently elected to put 18,000 households back through the renewal process to give them a second opportunity to auto renew, given some of the recent enhancements to our auto renewal process. The reason that we're so focused on auto renewal is because one, it's best for the member to have the opportunity to renew. They don't have to take action. It reduces member burden, and it's the place that we want to land where members are getting the best benefit they're eligible for. It also, from an operational sense, means there's fewer envelopes going out, fewer papers to process, fewer calls to the call center. So it's really across the board. What we want to make sure we can do is whenever possible, auto renew someone. While we're doing everything we can to support members, we do anticipate later this summer, we will see that reduction in caseload, particularly based on the trends that we're seeing across the US. So in addition to all of the planning and initiatives that we have live, there are a few additional measures that we're taking to really try to be responsive to what we're seeing across the US. The first, as I just mentioned, is we're really focused on improving our auto renewal processes, reducing the number of members who even need to reply to a blue envelope to maintain coverage. The second is we're starting to partner with health plans, not just to alert members that they're up for renewal, but to enable health plans to directly assist members to complete their renewal and applications. The third is continuing our close coordination with the Health Connector and employers to make sure that individuals who lose MassHealth coverage can find a place to land either on the Health Connector, through employer insurance, or other insurance opportunities. And finally, we're continuing to explore new ways to outreach members in their community. Recently working with Market Basket to do flyer and tabling, and also coordinating with libraries and schools across the state. I'm really appreciative of the opportunity to come here and share a little bit about what we're doing at MassHealth to support redeterminations, and we will continue to keep you updated throughout. Happy to take any questions now or after the broader update. Nancy, I think your
Thank you.
hand's up.
Yeah,
Nancy.
great. Yeah, great. Thank you. So first of all, thank you, Elizabeth, so much for coming. It's just so helpful to hear directly from MassHealth. So we appreciate that. The dashboard looks great. I really look forward to going in and playing around with it. Is there anything on the dashboard? It was kind of small. I couldn't entirely see that has projections of where MassHealth is thinking we will be at different points in time, or even like by the end of this process, based on the knowledge you have about who likely will and won't still be eligible, where we're thinking we'll end up. That seems to me to be really important to, at the end of the day, to sort of know how we're doing.
A great question, Nancy. Right now, the dashboard doesn't have that perspective looking view. We're really focused on representing what we have seen happen. Right now, we do anticipate our caseload will land around 2 million at the end of this process.
Okay, that's helpful even in terms of contextualizing it when we look at it. And then you said at the beginning, I think that there have been 331,000 redeterminations. And that look like the caseload hasn't really changed. Is that because those people are still within the 45-day window, or are they all redetermined, or people have added,
Yeah,
and time people have left? Like, what's going on with those folks?
It's a little bit of all of that. So those are renewals that we've initiated, meaning we've selected them, attempted to auto renew them, and then sent them their blue envelopes. Because members have 45 days to respond, and because we started the slow ramp up, a lot of those members haven't reached the end where they would necessarily lose coverage if they don't respond or have had an outcome of their redetermination. We also did elect for 18,000 of those members to restart this process to give them the best opportunity to auto renew. That being said, there are members who have replied and who have lost coverage there because they're no longer eligible. There are members who have returned their renewal and been eligible. There's members who've been able to renew. And of course, as always, there's members who are joining MassHealth. The dashboard is a helpful place to kind of be able to slice and dice that a little bit more to see exactly where we're landing at that still roughly 2.4 million.
Yeah, great. That's very helpful. Thank you.
Any other questions? I mean, I think the one takeaway I have is that it is still early days, and I think the the 45-day challenge, if you will, starts pretty soon, right, Elizabeth? The people who were in the first wave are starting to hear now, and
that's correct. Sorry, Secretary, please go.
I mean, one thing, I don't know if this is possible, following on a cohort basis could also, which you may be doing, but if they're, if people are kind of being renewed in tranches of people.
Oh, that's a good idea.
Each of those tranches separately to see what's going on within a group, as well as looking on, because I mean, as you've just explained to us so clearly, Elizabeth, there's so many moving pieces that trying to figure out if the end result is a good one, a concerning one, a miraculous one, it's just hard to know. So maybe that, I don't want to tell you how to do your job, but that would, maybe give a little bit of insight into that. And you may already be doing that.
Well, I also think it's important.
That's really helpful.
Yeah, to see if there's disproportionate effects on people that we're not reaching as well as we thought. So, I mean, there's tranches in terms of time when people were auto renewed, but there's also tranches of, I don't know, I'll make it up, people live on Cape Cod or, and so I think that's actually really good feedback. I mean, of course, we could cut this 1,000 different ways, but I think the database is relational and gives us the opportunity to do some of that as in real time as we work through it.
Yeah, and I saw that there were particularly, communities we care them, whatever you all think will give you the best insight into how things are going and how you might kind of recalibrate and adjust if you don't like what you're seeing.
So I think Audrey might convene and Amy Rosenthal are in Worcester later today, so we'll probably have a Worcester cut by the end of the day. But,
that sounds right.
Any other questions or concerns? I really cannot thank the team enough for the care and attention and just very detailed work that it takes to get us this far, and know that we're only we haven't even hit Heartbreak Hill yet. So this is a marathon, and we're going to be at it for the rest of the year. But if people hear anything or if something occurs to you afterwards, I'm sure Elizabeth would be, just drop her a note so we can think more comprehensively about this transition, which, with the goal of really preserving coverage for as many people or making sure they get to the right place, which is, I think, the next part of the conversation. So. Is there anything else? Okay. So we're going to move on. Okay. Thank you. Is this Marissa or you, Audrey?
This is me, Secretary. So I'll take over from here with the Health Connector components of our update. So we saw enrollments begin to tick up for July with over 8,000 new members coming from MassHealth. Overall, about 22% of the individuals who are eligible for a Health Connector plan after losing MassHealth have enrolled with us, a rate that is higher than some of the preliminary data we've seen coming out of other states, as well as an assessment of our own data on pre-COVID transitions. But I would caveat that these kinds of comparisons are very challenging to make, given the broad range of approaches that states are taking to their redeterminations, including their timeframes, their priority populations, and their level of integration with their marketplace. And further, this is still early days here, as you've noted. And while we're ahead of forecast, we remain really focused on the larger volume of renewal activity that we know is coming, particularly associated with open enrollment. In preparation for that increased volume, we've been deepening our understanding of who isn't enrolling so that we can support them in a targeted way toward finding new coverage. In the top chart here, you can see that the subsidized individuals are making up the bulk of the people who are selecting plans and enrolling in coverage after losing MassHealth. And among those who are eligible but not enrolled in this top bar here, you can see that 40% or about 22,000 people don't qualify for subsidies. And looking more closely at what's blocking them, about half of them have other coverage or access to other coverage that we can see in their application that's precluding them from subsidies. And that's a really different kind of person from the 35% who were denied for administrative reasons, where we're missing paperwork to be able to put them into a subsidized benefit. So we know that these individuals may need different kinds of supports, and we're looking at ways to provide those in a targeted way. We'll also be augmenting this information with surveys to the eligible but unenrolled and other qualitative information from those who work directly with individuals. And we'll be monitoring broader enrollment trends with DOI and with CHIA to look big picture at whether we're maintaining the state's overall coverage rate. Next month, the MassHealth redeterminations process will intersect with our own annual redeterminations. And we have a particular focus on what we call mixed households, those with some members on MassHealth and others eligible for QHPs. We've historically aligned with MassHealth such that these households do their Medicaid renewal at the same time that we do our annual review, streamlining the process for the family. This year, we have over 140,000 mixed household applications that will be selected for renewal in late August, early September, with the majority of those coverage transitions for anyone moving from MassHealth to a QHP generally occurring in January. We're expecting increased interactions with members once those redeterminations go out, as we know they often prompt application updates. So we are busy preparing for that. And before I hand over to Jason on outreach, I can pause for any questions. Eric, I see your hand up.
Hi.
Eric.
Yep. Thank you. You mentioned the 22% earlier and that it favors reasonably with other states. I was wondering if there's any states that are really hitting the cover off the ball. Is there anyone hitting 40, 50% or something around there that we can maybe learn from? Is there anyone doing anything uniquely well so far that we can gather some information from at this point?
So far, I have not seen anything, I would say, even beyond the 22% that we've cited, but not all states are reporting yet. And again, that goes to some of the note on timing. Some states are really just getting rolling with some of their processes. We're expecting to get data from CMS that's kind of on a standardized template later this summer that will allow for some comparison. But again, with that caveat, depending on who they're selecting, as a priority, those numbers may look different. And I would flag one state that will look a little bit different is California. They had a law passed a few years ago that requires automatic enrollment from Medicaid to exchange plans for anyone who's moving. So they'll show a 100% rate of plan selection among those people. But that doesn't mean that they'll all effectuate coverage. If they owe a premium, they'll still have to pay it in order to to maintain that, but the exchange will have kind of that direct insight into plan selection. So, we'll need to see how that rolls out, but that was a statutory provision that they have been working on implementing for a few years now.
Yeah, thank you.
Nancy?
Marissa, could you remind us, it looked like almost half of people had other coverage available? 47.
Among those unsubsidized individuals who have not selected a plan,
Yeah.
yes, it is about half. And so when we think about who's not crossing the finish line, that's a really good reason to not cross the finish line with us, because you're covered at work or because you've transitioned to Medicare. And so those people, I think we can be less worried about than the other people who need to send in some paperwork and they may need help to do that, or maybe have other eligibility updates that they need to make. Or even the people who are subsidy eligible, who may be confused about the process and need some help figuring out what their next steps are.
Could you remind us, is there an income, like you could be eligible for employer coverage, but it's just not affordable to you because of, can you remind us is there an income, is that the 9.5%? Yeah.
It is a 9.5%. It's indexed annually. This year, I believe it's 9.12% of your income. So if your employer plan is more expensive than that, you could get tax credits instead.
Yeah. So there are some protections for people in terms of whether the coverage is affordable or not.
That's right.
That's for employers with 50 or more
right
full-time equivalents.
Right. So, okay.
Any other questions? All right, I'll hand it over to Jason then. Thank you.
Thanks. Hi, Marissa. Good morning, everyone. Just a handful of quick updates here. We do continue to reach out extensively to people who are moving from MassHealth and are now eligible for Health Connector coverage. Through June, more than 200,000 messages had been delivered across the various available contact options. And as we move through this redetermination process, we are always evaluating any needs for new communication. For example, starting next week, we're going to start sending countdown communications to people who are leaving MassHealth but haven't reached their termination date. For people who get unsubsidized eligibility through the Health Connector, we'll send out an email every week to people who are sort of in that 14-day period between notice of MassHealth termination and their actual termination date. So they'll get 2 of those. And then for people who get a subsidized Health Connector eligibility, they terminate at the end of the month in MassHealth. So on the 15th, they will get an email from us saying you have 1 week to the 23rd. So it's a little bit of a twist on the deadline awareness. And like I said, those will start next week. By the time this month is over in July, we will have sent out nearly 30 different messages just in this month. This includes the weekly initial emails to everyone who's brand new to connector coverage, the countdown communications I just mentioned, and some other more targeted messaging. So no one's going to get 30 messages this month, but it's safe to say that they will get many. So that we continue to go sort of full boil on direct communications at this point. Next slide, Marissa. Thanks. In terms of public outreach, we continue with our enrollment events and our community-based visibility events. We've gotten almost 20,000 people to these events so far. Our navigators are seeing some busier than usual activity for this time of year. They've been participating in the enrollment events, and they're also taking incoming people who come to their locations. We are working on giving navigators expanded opportunity to reach directly out to people in their communities on a proactive basis. If somebody comes in and we know that they're newly eligible and they live in Springfield, we can get that information to navigators in Springfield and they can give them a call and encourage them to come in and get signed up. We continue to work on highlighting the role of employers in extending coverage to people moving from MassHealth. That includes yesterday a webinar we did with small businesses that included details on renewals. We do have a lot of good material for employers, employees on the need to ensure everyone has access to employer-sponsored coverage who can get it. We're going to continue to reach out statewide to business associations, large employers, and others to get the word out, especially as we see more and more people becoming eligible for other coverage out of MassHealth. And we do, Elizabeth went through the MassHealth dashboard. We do also publish monthly dashboards tracking enrollment and other member activity. And we expect the June dashboards to be published next week. For paid media, we're just about at full boil at this point. The out-of-home messaging on the T and billboards have been really very strong performers so far. 130 digital panels and T stations and 70 billboards around the state. I did see one on 128 a couple weeks ago, which was kind of nice. That 4.2 million impressions, the majority of that is from so far the T and the billboards. Paid media continues to encourage enrollment and the Health Connectors availability generally, but we are also targeting digital and social media messaging around the enrollment events to bolster awareness of those and attendance. In particular, targeted Facebook messages have performed well, reaching nearly 300,000 people in advance of the first 3 enrollment events. Our summer campaign intensity will bump up even a little bit more in the next week when the Women's World Cup starts on Thursday. The tournament's in Australia and New Zealand, so the game times aren't perfect. The US team plays at 9 o'clock at night twice and then at 3 in the morning for their other group stage game. But our partnerships in tournament coverage is throughout the day, so we'll be active and on when people are actually awake. And then we continue to do the zip trips with Fox. We were at the Southwick Zoo today, doing a little bit of a larger visibility there, but we are participating weekly in the zip trips. They have a photo booth set up on site where people who are there take a picture, and our logo is on all those pictures, and you kind of see them randomly pop up on social media from time to time.
Jason, are we only advertising during US games?
No,
Okay.
we're advertising on all games on Telemundo, and I think the same on Fox.
Great.
Any questions for Jason? Jason, do you have a way of measuring which venues are the most effective to reach people? I mean, because I'm struck by the, just the ground game here, and it's pretty extensive. And are there things, I wonder if there's an opportunity both on the MassHealth side and the connector side to sort of modify the ground game going forward as we see what works, because it could be, I'll use the Cape Cod example. Clearly I want to be on vacation, but it could be that we've oversaturated Boston. I'm making it up. And then the other thing that worries me a little bit is we sort of, we're going where our patients are predominantly, but wondering if there's places that, there's poverty everywhere. And it's hidden often, particularly in rural areas. So wondered a little bit about like how we keep our approach fresh.
Yeah, so it's something that we definitely will keep an eye on, take a look at the numbers, adjust as necessary. I think that we do hope, the billboards are statewide, for example. That's a place where we'll see those when they're on the highways. The TV is probably where we get the best, sort of very broad-based. And then, we can always target, particularly on social, like I said, the paid social media. If we find we need to bolster the Cape, for example, we can start pounding messages down there harder.
And then to Eric or Matt's question, it would be good to share best practices with other states, like what's worked, because there's a lot of material. Like if you travel anywhere, maybe I'm sort of attuned to it, but I see these signs kind of everywhere. So wondering, well, I was in New York a lot, so that's kind of be an obvious place to see it. But anyway, just, I think this is just really important work because obviously, people don't think about their health insurance until not it's too late, but until they need it. So everybody's not stating the obvious, which is what I do for a living. So anyway.
And I would just echo the sentiment around we want to be really evaluating our strategies as we go, not just on media, but even thinking about the partnerships we have with carriers. Like we might be able to see best practices if certain carriers are using a particular communication strategy. How do we raise that up and import that to other carriers into what we're doing? And would just stress on the the interstate comparisons and note sharing. We're in really regular contact with other state-based marketplaces, so lots of exchanging of best practices happening there. And I think CMS is very committed to facilitating that as well. So evaluating our own strategies and looking across to see what we can learn that's working well in other places is a key priority for us.
Thanks. Any other questions or comments for Jason and the team? And I want to thank everybody for this presentation. I think we're on to the next topic.
I think we just have a couple more slides on
sorry.
the contact center and operations, and then.
Sorry. Don't we cut off the really important work at the call center?
No, back to Trish. Thank you.
Thank you. Good morning, everyone. So our contact center volume continues to rise incrementally with 4,000 more calls in June than we had in May. Our abandonment rate continues to be less than 1%, and our overall satisfaction level is over 97%. We do receive updates from MassHealth weekly. Their metrics are very similar to ours as far as service levels and abandonment rate. On the next slide, for operational updates, the Health Connector continues to prioritize proactive outreach to potential members to help them complete steps needed for successful redetermination. Our second vendor, Maximus, began operations on July 5th with their first wave of trained agents, and their second wave began on July 10th. As a reminder, their staff will assist us with outbound calls and then paper processing in the event that our primary vendor, Accenture, has to pull their paper processing staff to assist with inbound calls. The first campaign for Maximus is the identity proofing campaign. Identity proofing is a required step in which a person must prove their identity when they create an account on mahealthconnector.org. If they're unable to answer the questions during account creation, they have to submit manual proof to us. This step helps prevent fraudulent use of a person's identity to sign up for healthcare coverage. While a potential member can still contact us by phone to complete an application, can request an application by mail, can print out an application, we do encourage folks to do online applications since the process is much quicker. In an effort to help individuals finish their setup so they can complete their renewal online, we've been contacting individuals who need help completing their identity proofing. As of July 10th, we have Maximus had contacted 7,900 people. 5,700 of those contacts were either speaking to someone live or leaving a voicemail. 2,200 were either no answer or a bad number. As of this morning, the number of contacts left is about 10,000. So they've been working through that initial group of 21,000. And that 21,000 is both MassHealth members, MassHealth members, and Connector members. So it is a mix of both. For the remainder of July, Maximus will continue to reach out to newly eligible Connector members to encourage them to shop for and choose a plan. They will also have a call campaign where they'll reach out to Connector members who have chosen a plan, but still have to pay their premiums. By the end of July and into August, Maximus will begin to reach out to those mixed households that Marissa was speaking about earlier to alert them that the blue envelope is on the way. They need to fill out the paperwork and get that paperwork into us as quickly as possible. On the next slide, we've reached a final agreement with our primary contact center vendor, Accenture, on the call volume forecast and staffing levels for the remainder of the unwind period, which brings us through March 31st of 2024. In addition to those staffing levels that we've agreed upon, we do have a group of FTEs, which are our buffer staff, and they are available to help both with inbound calls and outbound calls right now, and they will be helpful if there are any spikes in volume. Our expanded interactive voice response menu and messages will go live late July. This will allow callers who are non-English speaking to be able to navigate menu options and hear hold messages in their language until they can be connected to an agent who already has the appropriate interpreter on the phone. Finally, we continue to recruit, hire, and train outreach specialists for our mobile outreach team. These individuals will provide support throughout Massachusetts by assisting individuals in shelters, libraries, pharmacies, food pantries, town halls, and any of the outreach events that are being set up and coordinated by MassHealth. Happy to take questions before I turn it back over.
Any questions on the always fascinating call center? But so important.
All right, thank you.
All right, great.
All right, so as we move further into the redets period, we'll continue to provide you with updates and findings about what we're learning and how we're adapting to maximize our successful coverage transitions for members.
Great. Thank you, Marissa and team. I really appreciate the update. I know the board does as well. And we'll just look forward to further updates as we move forward. All right, I think I'm turning it over now to Marissa again, who will, and I'll remind my fellow board members that this will be looking for a vote at the end of this presentation. Thanks, Marissa.
Yes, so switching gears now, Sam and I will review carrier responses to the seal of approval RFR that we issued in March, outlining the Health Connectors plan certification process for 2024, and request a vote awarding the conditional seal of approval. We'll return in September with recommendations for the final award of the seal of approval based on additional review subsequent to the completion of the Division of Insurance's form and rate filing review. And just as a refresher, the 2024 SOA included a product shelf very similar to the one we have in 2023, which Sam will describe in more detail. And it also requested information and action from carriers on topics of interest, building on initiatives that we've refined over the last few years. Of particular interest this year, we plan to work with carriers on ensuring members receive preventive services, especially PCP visits, certain cancer screenings, and for our dental carriers, regular cleanings. We also embedded in our plans continued $0 access to high-value preventive care in light of the recent Braidwood court case, which you'll hear about in our MCC presentation later. Secondly, we continue to monitor developments in the maternal health space and expect issuers to as well, including promotion and future coverage of doula services to combat disparities in maternal health outcomes. And finally, we're working to make it easier for members to find provider information related to behavioral health and community health centers. And this is all on top of the initiatives from prior years that we've done, removing cost sharing for medication-assisted treatment and certain chronic conditions, as well as alignment with the state's behavioral healthcare roadmap, and those remain in place for 2024. So with that, I'll hand over to Sam to go into more detail.
Thanks and good morning. The 2024 product shelf is represented by 8 medical carriers, submitting a total of 46 non-group and 56 small group qualified health plans. Each issuer is required to offer a standard plan design on platinum, gold, silver, and bronze tiers. And these standard plan designs seek to provide copay first cost sharing with focus on reducing cost for primary care visits and generic medication for plan enrollees. In addition to the 8 existing health issuers, 2 existing dental issuers seek to offer plans on exchange for 2024. Connector care plans, which are the cost share reduction variants of the standard silver design, will newly be offered from Blue Cross, Blue Shield, Harvard Pilgrim, United Healthcare, and from Mass General Brigham Health Plan's broadest network. These offerings will be in addition to the existing connector care carriers, which are Fallon Health, Mass General Brigham's limited network, Health New England, Tufts Direct, and WellSense. And here we show the overall product shelf submitted for consideration. Standard plans make up the majority of the offerings from issuers, which is about 80% of the plans offered. The non-group shelf remains stable compared to 2023 with no plan closures and minimal cost sharing changes. These plan counts also, they reflect the total amount of plans for QHP certification for 2024. So members' choice of plans will vary by their zip code and program eligibility. The small group shelf is also consistent.
Wait, can I just make up a question, Sam? I didn't understand that. So in theory, I could not be offered a gold plan if I lived in Pittsfield. When you said by zip code, I just wanted to clarify that.
Yeah, it's more related to the carrier's service area. So a member would have gold options, but maybe not from each carrier. The small group shelf is also consistent with 2023, and the notable difference between non-group and small group offerings is the ability for employers and employees to select an issuer's low silver plan design, which is an HSA compatible plan, and also select from PPO offerings.
So Sam, just going back to the secretary's question, there may be some zip codes, I don't know, like in Boston, where people have dozens of options, and there may be other zip codes in a more rural area where they'll have each type of product available, but not as many carriers potentially.
That's right.
Okay.
Yeah, and the traditional example is Cape Cod, the islands have a few less options than Suffolk or Worcester or other areas. And Eric, I see you have your hand.
Yeah, I just wanted to articulate a thought as I've been thinking about this topic of expanding the carriers on the Connector Care platform. We're adding networks that are broader and adding a PPO, sounds like, options. And I think it's always a delicate balance looking at access to providers with cost controls, short and long term. And so just want to point out for the board that best practices in the industry are increasingly to recognize that different providers cost different amounts for the same services. And the industry is looking to leverage that fact to try to steer people towards lower cost providers. And by offering broader provider networks, in some sense, we are going against some of those best practices. So I just want to encourage the connector and us as a group to continue to look to cost controls. So related to that, by adding in those broader networks and the connector, I'd want to make sure that the connector or the state isn't having to subsidize further to offer those broader networks to folks where they currently have access to more limited networks. I think choice is a great thing, as long as it still has an element of cost control in the goals here.
Thank you, Eric. Michael?
Yeah, so I'm going to say something I think very much in the spirit of what Eric said. So I agree that the choice is good. So if I understand correctly, the choice will vary, but it's going to vary the way choice varies around the state anyway, just for other insurance. It's not specific. So you're just seeing which carriers are where, as opposed to anything specific that the carriers are choosing to be one place just for the connector versus not. I think that's what I heard is how this plays out. And I think the issue is that, while in general, I agree that choice is good and I'm supportive of what we've done, people don't always make the right choices and choice can be overwhelming. And so if everyone made the right choice, you might not worry about a broad network, high cost plan. People would still choose the lower cost narrow network if that's what they preferred, and it wouldn't be a problem. But people can sometimes get overwhelmed by choice, not know what's going on, and make choices that might not be optimal. So I think it's important to really understand the support and the choice architecture. And if there's plans, for example, that are offered, but no one's enrolling because they're just way more expensive than other plans, we might not be getting a lot for that added choice. And we might want to think about what's going on as we move forward, because having something there just to be complete might not be valuable if it's something that most people don't want. And some of the people that could end up there do so by accident.
Audrey, do you want to respond? I saw you nodding, or should we take Rena's comment and then maybe I'll have to ask the connector team to
Or
information. Yeah. Oh, and then Nancy, Rena, Nancy, and then you.
Okay, yeah, let the board member speak and then I can respond.
Yeah, actually, Audrey, I was going to ask you or someone from the connector to provide a little bit more explanation to Eric's question about, is this going to cost the state more money? Because I think the answer is no, because at the end of the day, we only subsidize, the state only fills in the gap relative to the, to a certain amount. But it might be helpful if you provide some additional context to help in that area.
Sure. So I'm happy to speak to that. And then Nancy, I see your hand, so I want to make sure we hear from you as well. So just kind of backing way up for context. So last year, as part of our seal of approval, we'd made this decision that we were going to say no longer within the Health Connector can you be a carrier who's participating in the marketplace, but you're not participating in Connector Care. And that was for a variety of reasons, really to do with kind of fairness and saying we don't really want carriers to be able to cherry pick and say we're only going to serve higher income enrollees through the Health Connector. The Health Connector really stands alone as a marketplace across the entire country and allowing carriers to pick and choose whether they want to only serve, moderate and higher income individuals. And and the other reason I would note is to do with the fact that in connector care, because we've only had a subset of carriers on the marketplace serving the connector care population, we've had parts of the state where we're down to one single carrier servicing a region, which has made us very, very vulnerable to carrier shifts in ways that have been frankly frightening over the years. So part of our interest here was saying, let's just get the entire suite of carriers into the connector care program. As you all know, the Connector Care program has been dominated by narrower network products than some of the carriers that will be coming in 2024. We have no intention of shifting strategy in terms of that continuing to be a very viable and important part of the product shelf within Connector Care and frankly, the entire marketplace. And what we're trying to do here is say people who are subsidy eligible shouldn't not have the option of buying up to a higher cost, broader network plan. There's all sorts of reasons that we're not here to pass judgment on. Someone may want to buy up to a plan. Maybe they have a mental health provider they've been seeing for 15 years. They lose their job. They don't have ESI anymore. Now they're a Connector Care enrollee. And we've had to say over the years to consumers who've called the Connector and said, I'm a Connector Care eligible person. How come I can't get to my provider? I'm willing to pay more for that carrier and they can't. So that just to provide that context and why we went down this particular road. So to your question about, is there cost to the state here? In the past, as this board knows, we have historically subsidized some of the difference between plans that are at different plan levels, but maintain the rank order and continue to show differences between plans. And we usually make those determinations for an upcoming plan year after we have final rates from plans. But the intention here is not to erase or even significantly shrink differences between the very bottom cost and the high cost, particularly because some of these plans coming in, we don't want to speculate before the DOI process is over, will be higher cost. But the purpose here was to give people the choice of buying up and not having the state erase that difference, but just provide a choice for people, just as a matter of fairness, frankly. And Nancy,
thank you. Secretary, I actually was going to, in a different way, make the point that Audrey just made, which is that we've had a very bifurcated market where people whose incomes are low have had, for the most part, much more restrictive provider networks as a way to control costs. And I don't believe we've really ever had much of a robust conversation at this board or in other public places about that and how unfair it's been. So I think the move towards broader networks is a really good one. And of course, people have, I'm sure, made bad choices based on price, where they have found themselves in plans where they have not understood how limited those networks are, or where they have not had access, and often significant access to the kind of mental health services and other things that they need. So it's also possible, now that we're bringing 3 new carriers into Connector Care, for example, when there are 200,000 plus members who are going to be making choices of what plans to buy, that competition among the carriers, who at the end of the day are the ones who've negotiated those high-priced contracts with certain provider networks, might be eager to have more members in a market that's otherwise pretty stagnant in terms of enrollment changes. So it's possible they could sharpen their pencils, and we might see some good effects in terms of competition among them. So I think it's going to be I'm very supportive of requiring all the carriers to participate broadly in our market and not be able to pick and choose. But I think it's going to be an interesting experiment to see how this plays out in terms of member choices and premiums and other things.
Matt and then Mike.
Just a brief comment, and I want to second all the prior comments about the strategy and in support of the strategy. When it comes to the impact of high costs on taxpayers, and we've particularly in this discussion focused it on the state's budget obligations. I just want to always remind us to also have in mind the federal budget impacts as well. We are in many ways stewards of those federal dollars as well. And I just always want to not lose that element of it.
I think that's really important. I'd forgotten that to just that moment, just this moment. So thanks, Matt. Michael.
Yeah, so just to be clear, I am also supportive of what we did. We talked about this before, and I, for all the reasons that Audrey said and was seconded, I think it's important to do this. The challenge it places is when someone enrolls in a broad network plan, it might be because they're really aware that they're going to get charged more in terms of a premium. They're going to get access to more physicians, and that broad access is really valuable to them. But it may end up that that didn't happen. If you look at a lot of other plan choice literature, people choosing Part D, right? There's a choice notion that people weigh the, say, breadth of the network and the premium and a bunch of other things sort of very rationally. The more choices they have, people often don't choose as wisely. They don't spend as much time doing things. And so they end up in plans that actually don't reflect their preferences for a range of ways. I think for all the reasons you said, Audrey, we need to do this. I think the worst risk is to have areas where there's no carriers or that things can be very unstable. I think that's the bigger concern. That being said, once we do this, I think we need to make sure that we don't end up in a situation where someone's in a plan and they just didn't understand that they chose a much higher cost plan when a lower cost plan was available to them. And they just didn't understand or see or figure out that that was the case. And they got charged more and now they're paying a lot. They decide this is too expensive for me. And they don't realize instead of dropping coverage, they should just move to a narrow network plan if that's better. It's just harder to get people to make choices when there's more choices to make. And there's a lot of evidence that busy people, a lot of things go on in their lives, sometimes end up in more expensive things that they'd rather not have ended up in. It's just they got overwhelmed by the choices. And we need to see how that plays out.
Absolutely. Thank you. Eric?
Thank you. I would just add to that this is not the first time that these challenges have been presented. This is in the industry broadly, these challenges, and a couple things that have been brought up in the market, which we may want to think about in the future, is increased technology to help people make choices. So that's made great progress. I know we have some tools on the connector site, which I really like. I've used it for people to just check it out, where it asks for your doctor, for your prescriptions. There are tools similar to that and stronger than that would ask people what who their doctors are, what their frequency of usage of those doctors, hospitals, what kind of prescriptions do they take? Are they brands? Are they generics? And it has algorithms underneath it. So early version of AI where it does the math, and it says based on all the responses that you just provided, who you see, how often you see them, what you receive, and comparing that to the copays, deductibles, and networks, and the premiums. Here is the most natural plan given your expectations and utilization. It does require someone to do a little extra work, but some of these are really gamified. These tools are really gamified and fun. So that may be something, as if we're offering more choice, oftentimes you want to offer tools to help people manage and manage those choices and find the right plan for them. And the second thing I'll say is we're talking about an either or situation with full network plans, which are very expensive, or narrow network plans. But there are middle types of plans. There are tiered network plans where you can go to anybody you want, but you pay a different copay depending on which hospital you go to. There are other plans where you pick based on every service that you receive. So if you're about to need an MRI, you go online, and one of our carriers that we offer today offers a plan like this, where you go online and you can see dozens and dozens of providers that offer an MRI, and their different pricings all across the board. It's almost like an Amazon buying experience. So I would encourage us to be thinking along those lines as we look to, offer these broader choices, but then offer abilities to to choose between them, and then some middle paths.
Thank you.
Audrey, did you want to comment specifically on Eric's?
Oh, I would just say that we have been exploring the idea of more nuanced decision support tools over the years. We've had some kind of challenges with how we embed those technologically in the online application and shopping experience, but would love to think with you and this board more about that. We agree it's vital. Our experience is people are very, very price sensitive shoppers. And so price ends up being, in many cases, the most significant factor for people as they shop. But there's so many different factors to consider in terms of anticipated health events and costs and provider access and the rest. So I agree, there's just a lot, I think, for us to think about there, especially as we balance choice with, ease of understanding and making sure people understand what they're getting into. So point very well taken.
Thanks. Matt.
Yeah, just at the risk of extending this discussion further, just a brief comment. We struggle with this as well with a much narrower portfolio of plans. So just to second Eric's comment that this is a common feature across all of insurance. This is complicated stuff. And we also give at the GIC are constantly trying to determine ways that we can better support our members through more sophisticated decision support tools. Audrey and I talk about ways in which we can align and collaborate on these sorts of things. And this is one, I think, that we can probably bring some value to each other as we evaluate those tools. To Eric's point, there's just on the technology end, there's so much that's happening here that we can leverage.
Thank you. I'll just observe that it just shouldn't be this hard to get health insurance, but it's probably totally not productive comment. So let's move on with the presentation because our vote doesn't come to page 49 and we are on, well, now we're on 40, so we're getting there.
Yes.
Audrey, how am I doing on time?
Okay, the last two presentations are quite brief. So I think as long as we're through this one, I would say by 10:30, 10:35.
Okay, just give me the cut sign if I
sounds good. Thank you.
And the conversation is really interesting, but
it is. Yes. No, we don't want to cut off the great questions and discussions.
Thanks, Sam.
Sure. Yep. I'll keep it moving here. So for members not eligible for Connected Care, there are also a few non-standard offerings. There's a low gold offering from every carrier. And 2 carriers offer non-standard bronze offerings, and there's also a small group only silver plan. There are also 2 catastrophic plans, which are plans for a member who is under 30, and it's kind of the stopgap coverage plan. So 2 carriers are offering these plans, while 6 issuers are requesting a waiver for sale on exchange, and staff recommend approval of these waivers as the 2 offerings provide sufficient choice statewide, and these are also existing plans in 2023 and in prior years.
Sam, what proportion of our members are in non-standard plans? I mean, they clutter up the product shelf. Are they popular, or they also provide a lot of opportunity for risk selection and gaming? So notwithstanding Eric's comment that gaming is fun in health insurance, but why do we offer them if there are there's not a lot of demand?
Yeah, I don't have a full count. I know some plans have very low membership. Is it
intent part of the market? Don't we have to offer it, Nancy?
Non-standard? I don't know.
No.
We don't have to. One thing I will say, just as a historical note, was I believe, somebody can correct me, when the connector started, we were very much focused, I think, exclusively on standardized plans. And I think it was when we started to make entry points into the small group market that there was a lot of feedback that there was kind of innovation happening that sort of lived outside of the scope of our standard plans, that we wouldn't really be able to attract small groups if we weren't offering some of those non-standardized plan designs. So that was kind of what opened the door. They've definitely remained a minority of our plans and our enrollment, as I understand it. We can certainly circle back with specific data. But I think it's a fair question if it's worth a fresh look at, because there is a lot of value, coming back to our earlier conversation about allowing people to make clear choices. Standardizing plan benefits is a great way to do that, because you can say every gold plan looks like this. You're making an apples to apples comparison.
Yeah, I think if you're going to bring them forward for a final vote, we should, just be clear about why we think they're bringing value.
Yeah.
Sure. And I'll also mention for the low gold, we fix the AV within a specific range. And the intent there was to have a high value option that's lower than the platinum and the high gold. So that we try to get a competitive price there. So moving on to service area changes, there are 4 issuers presenting changes in this QHP landscape. So at the issuance of the RFR in March, the Health Connector newly required for carriers on and off exchange service areas to match for all QHP offerings, including for connector care plans. The following 4 changes reflect that intent for service area parity, both on and off exchange and in and out of the connector care program. So leading off, Fallon is requested to expand their on-exchange service area to Berkshire County and Suffolk counties to serve all zip codes in those counties. Additionally, Fallon requested to serve a portion of Norfolk County adjacent to the Boston area and requested to cover Worcester County in full in order to cover some previously excluded zip codes in that region. The intent here is from Fallon is to more closely align with their Medicaid service area, particularly in light of ongoing redetermination. This proposal was reviewed in coordination with the Division of Insurance. It demonstrated adherence to the network adequacy, time and distance standards for PCP geographic access and other key specialists. And connector staff also considered availability of inpatient hospitals, community health centers, and community behavioral health centers in network within each county proposed. Health New England will exit from Worcester County, which impacts about 700 individual and 200 small group on exchange enrollees, in addition to members enrolled off exchange. This change does not impact H&E's Connector Care Program membership, as H&E previously withdrew from Worcester County from the Connector Care service area in a previous plan year. And they remain focused on delivering services to members in the westernmost counties of the state, as they are a regional carrier there. United will expand their service area from Suffolk and Middlesex only in 2023 to statewide coverage in 2024. And WellSense will offer all plans, so platinum, gold, bronze, silver, on their broadest service area in 2024. This service area is previously unique to silver only plans, so there'll be new offerings from WellSense available in about 455 zip codes, and that includes areas like Springfield, Worcester County, and the Barnstable County, Cape area, as well as others. Moving to some narrative responses, we received these to help design some future policy direction. We asked carriers about intent to seek the National Committee for Quality Assurance, which is also known as NCQA, new health equity accreditation. We surveyed carriers for information about language preference and interpretation services offered to support members whose primary language is not English. We also requested descriptions from carriers about how algorithms are used to establish risk profiles in care management and how they mitigate bias in those profiles. And finally, we asked about policies in place in the event of member displacement or emergency provider access needs in the event of climate-related impacts. And circling back to Connector Care, we have a preview of the program, but the focus of September's board meeting will really dive in more detail. We anticipate including at least 5 Connector Care offerings and as many as 8 per geographic subregion. So in comparison, in 2023 or now, if a member was Connector Care eligible and went into the application to select a plan, in some regions, they would have as few as 1 option and at most 4, depending where they lived. The final rates in September will inform the enrollee premium contributions for each plan selection. Additionally, staff are closely watching legislative developments related to the proposed 2-year pilot expansion of connector care to 500% of FPL, and included in the fiscal year 2024 House budget. And just as a reminder, the current FPL cap in connector care is 300%. If signed into law, staff is prepared to hastily update SOA RFR materials and communicate new program parameters to carriers. At this time, we've posted a notice alongside the RFR about anticipated updates, and we'll be prepared to reissue amended contract material.
Sam, is there a deadline in your mind? Like if the budget has, continues on, I mean, we'll probably wrap it up soon, but is there a deadline where we need to know because getting to 500%, that's a lot of heavy lift for the team. Or maybe it's an Audrey question. We'll kick it up.
What we would need is for it to be determined before we run preliminary eligibility. And Marissa, I might need your help on exactly when that is. I think it's in August, maybe mid-August.
Yep, we usually start around August 15th. So we would need to be settled before then.
I don't think we're going to get to 500, but we'll see.
We are just monitoring and ready for whatever may transpire.
I hadn't connected those routes either. Okay. Sorry, I was trying to pick up time and then I interrupted. Keep going, Sam. Sorry.
No, it's okay. Just on QDP, qualified dental plan offerings for sale on exchange will be identical to 2023. We have 2 carriers, Altus and Delta. They'll continue to sell plans on exchange for non-group and small group. Blue Cross Blue Shield Dental will seek they'll seek QDP certification, but are asking for a waiver for sale as they've done in previous years. And Guardian Dental will not seek QDP certification this year in Massachusetts as they have in previous years. Yes, Eric?
Thank you. Have we had discussions yet with the carriers regarding their commitment to remain in connector, given the change in target loss ratio, minimum loss ratio? I know there's activity there with the DOI working through that, but just curious if we have a commitment yet that they're going to remain in the market, because it's interesting that Guardian removed themselves. I'm wondering if other small networks might do the same, although we have 2 of the largest ones. I think Blue Cross and Delta are pretty safe. I just don't know on the individual market what they're thinking they can do in order to hit the 83.
Yeah, Marissa, you can jump in.
Sure, we have not had conversations with the dental carriers beyond plan year 2024. So you can see Altus and Delta have committed for 2024. But I think we're just closely monitoring the process that the Division of Insurance is leading with regard to implementation of that law, and we'll continue to see how things evolve in that space.
They could probably fund continued participation for a few years out of all the profits they made during COVID on dental insurance.
Yeah, and it's my understanding for Guardian that they've withdrawn from Massachusetts in full, so not just on exchange. So next steps, we will work to present the final recommendations for the seal of approval to this board in September. So carriers must demonstrate compliance with the federal requirements, DOI requirements, including network adequacy and completion of premium rate review, and adherence to the seal of approval form of agreement contracts. The recommendations based on the confirmation that the 2024 plan offerings have the board seal of approval, offer good value to our members and meet these standards. So today's vote, which is on the next slide, will enable consideration of all the recommended standard and non-standard QHPs and connector care plans, as well as QDPs proposed by the following carriers.
Thanks, Sam. Audrey, I have a question. Do I need to recuse myself because of WellSense? I mean, they're sort of on the list here. I was thinking I would recuse myself if we were going to vote against them or only vote for them, but it's kind of up to you
I
guys.
appreciate the question. I haven't been made aware by our legal team of any such recusals that would be necessary. I don't know that we have anybody from legal on the call who I think would probably be better able to answer that from me than me. But if you,
I'm slightly worried we lost a quorum with Martha. I should have grabbed her before she logged off.
it's okay. Kathy, do we still have a quorum if the
Oh.
secretary recuses?
Let me 1, 2, 3, 4, 5. We have 6. That's all we need.
So should I recuse myself just for safety's sake?
Yeah, I think maybe just to err on the side of caution, since you
Okay.
have the question, and then we can offline work that through our general counsel's office. Just
I mean, I don't think it is. I don't feel at all conflicted, but
okay. No, I appreciate that. We can take that back. But if you want to recuse that, I think that works.
okay. Well, other than my disrupting the agenda once again, I'm ready to, unless there's further discussion, and thank the team and Sam for the presentation. Is there any further discussion or questions? So can I get a motion?
A move.
Second.
Second. Okay, Kathy.
Okay. Rebecca,
Yes.
Michael,
Yes.
Eric.
Yes.
I'm correct to say Martha is no longer with us?
Yes,
Okay. Secretary,
I'm going to recuse. Thank you.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes.
Thank you.
Wonderful. The motion carries. Thank you. Okay, the next item is will also require a vote. It's on our fiscal year 2024 administrative budget. And Kari is going to kick this off. Thank you. I think we need to advance the slides as well.
Good morning. I'm trying to request. Okay, let's see. Just make sure this works. For some reason, the slides are not advancing for me. Oh, there we go. Sorry about that. Okay. Good morning, everyone, and thank you. I'm here to provide an update on the Health Connectors administrative budget projections for fiscal year 23. And then we will subsequently request your vote on the recommendation for FY24. As Audrey mentioned in her remarks at the beginning of the meeting, this budget was reviewed by the ANF subcommittee on June 27th. And for those that may be new to these meetings, I will take just a moment to provide some background. So our administrative budget funds our operating costs, and about 60% of these costs are for our major service vendors. And these vendors perform on our behalf contact center, enrollment, and premium billing functions. The remaining 40% of the budget is for costs associated with our personnel and contractors, technology, including the portion of the eligibility system or HICS that's allocated to us, as well as outreach and public education activities. Our budget is financed by an administrative fee on the carriers based on the number of covered lives in the exchange, as well as by the Commonwealth Care Trust Fund, or CCTF. As you can imagine, our budget has been impacted by the public health emergency because the Medicaid maintenance of effort protections have suppressed Health Connector enrollment levels. This is because individuals who would have naturally moved into the Health Connector over the last 3 years were locked in MassHealth coverage. But as the redetermination period progresses, we do expect to see significant growth throughout FY24. So with respect to 23, current projections result in a net position of 11 million, as Audrey mentioned, and our FY24 recommendation reflects the expected enrollment growth due to the redetermination period, as well as one-time investments in member support and outreach and education to assist residents that are migrating to Health Connector coverage. Fiscal year 24 is projected to result in a net loss of 6.6 million. However, this is offset by the favorable variance in fiscal year 23. So across the two fiscal years, we're projecting a favorable position of about 4.3 million. So as we know, we've talked about it at length. The redetermination process is historic. About 1 in 3 Massachusetts residents will have their eligibility redetermined. And we want to obviously maintain the Commonwealth's 90% coverage rate. So it is crucial that we do all we can to support these members during the transition. So to that end, This slide shows about $22 million in one-time investments that are reflected in our current budget projections for the Health Connectors work to support the Commonwealth's success in this redetermination effort. This ranges from additional contact center support to maintain service levels, a backup contact center vendor to make outbound calls and process paper documents, to additional outreach and education activities, as well as increasing capacity with our navigator partners. We also account for a mobile outreach team where we have about 9 people strategically located across the Commonwealth to assist residents near their homes. And about 80% or $18 million of these one-time costs is going to be funded by the CCTF. The mobile outreach team is funded by EHS. If there's no questions, I can turn to FY23. Okay, thank you. So this slide shows enrollment for the different populations that purchased insurance through the Health Connector. It shows individual coverage, both subsidized and unsubsidized, small group and standalone dental. Total enrollment for the current projection is represented by the blue line, while the gray line shows the enrollment that we had projected as of last July. It's 16% less compared to budget, and the reason for this, of course, is because the public health emergency was extended to April 2023, and our budget presumed an end date of October 2022. So this slide here shows our current fiscal year 23 administrative budget projections. For those of you that may be seeing this exhibit for the first time, I will go over it quickly. At the top on the left, you see projected member months, followed by our revenue and then expense line items. This is followed by 2 different views of our net position and reserves with and without GASB 51. GASB 51 reflects the one-time purchase of an intangible asset, which is depreciated over the useful life. This view is consistent with our financial statements. In our case, GASB 51 reflects implementation costs associated with our contact center and premium billing vendor. However, we also provide a view without GASB to provide a clearer picture of what our current net position and available reserves look like, given that this spending occurred in 2020 and 2021. So the columns reflect our budget estimates at 2 points in time. The first reflects those that were approved back in July of last year. Then we see our current projections and then a variance column. So as you can see, about 2/3 of the way down, we are projecting a net gain of about 11 million for fiscal year 23, which is a variance of 7.7. This is due to expense reductions of about 6.1 and a net 1.6 million in additional revenue. Regarding the revenue, the decrease in our carrier administrative fees is because of the suppressed enrollment. And then this is offset by additional CCTF funding for one-time costs in FY23 associated with those one-time activities to support the redetermination period that we reviewed on slide 3. We also have an additional, it's almost 2.5 million in investment income because of the higher interest rates. With respect to the 6.1 million expense decrease, most of this is in the contact center and premium billing line item. This is not surprising because this is due to lower costs for our vendors, again, because of the suppressed enrollment is generally they're paid a per member per month fee. We also have lower than budgeted costs for our share of the HICS, as well as other IT and administrative costs and personnel. This is offset again by the additional one-time activities in outreach and education that we will be engaging in to support the redetermination period. So I'll stop there to see if there are any questions on FY23 before we turn to FY24.
I think we're good.
All right, great. Hearing none. Okay, so this is our projected enrollment for FY24. It is about 30% higher than FY23, again, due to expected growth in the subsidized populations because of the redeterminations that resumed in April. For Connector Care alone, we are projecting an additional 100,000 members over the course of FY24. We monitor data available in the HICS with respect to the percentage of redeterminations that result in a Medicaid versus a QHP eligibility. And for those that are determined eligible for Connector coverage, We use historical data and other metrics to project how many actually may select and enroll in a plan. We have also taken into account the impact of the unprecedented outreach that Jason spoke about that it is currently occurring. So if there's no questions on enrollment, I can move to the recommendation for 24. Thank you. Okay, so on this slide, again, same exhibit. This is our FY24 recommendation, which is compared to fiscal year 23. As we've discussed in the overview and throughout today's meeting, again, this recommendation reflects everything that we've discussed, expected enrollment growth, and again, all of those one-time investments to support our members and help them cross the finish line. This budget reflects a loss of $6.6 million, but this is offset by the favorable position in 23. So again, it's a little over $4 million across both of the fiscal years. And if 24 ends up being more favorable than projected here, we are happy to work with ANF and EHS to reconsider the CCTF draw next spring. So compared to 23, we're projecting about $8.9 million in additional revenue. And again, this is because of the carrier fee, because of the increased enrollment. We are reflecting the funding to support the mobile outreach team. And again, additional investment income due to these the current interest rates. This is offset by a reduction in the CCTF draw to support our administrative costs. We are recommending that we reduce our draw to about $35 million, but we are accounting for a maximum of $9 million to fund the one-time costs associated with additional contact center capacity. Expenses are increasing by about $26.5 million, but of this, about $20 million are the one-time costs, again, that we looked at on slide 3. And the biggest increase is the additional $20 million for contact center and premium billing. This is for all those things we've already talked about: contact center capacity, a backup vendor. Vendor payments will increase because we're expecting more members. And we do have additional noticing and postage costs that are related to, again, the additional membership, as well as all the communications for the redetermination. We are also projecting increases for our share of the HICS. And as I said many times, additional outreach and navigator capacity to support our members. Lastly, personnel and benefit costs. This is partially due to the mobile outreach team, as well as some new resources and operations, executive and project management support. So the bottom line here, we're projecting for fiscal year in 24, about $44 million in reserves or so. Excluding one-time costs, this amount represents about half of our ongoing operating expenses. And that is at a level that is consistent with our auditor's ongoing recommendation. So I will stop there and see if anyone has any questions or comments.
My comment is that was a very clear presentation, but it looks like there's a number of questions. I saw Nancy's hand first.
Yeah, thank you. That was an excellent presentation. It's very clear. Could you remind us, so much of this budget, as we talked about at another meeting, it depends on what our actual connector care enrollment ends up being. So could you remind us what's the budget implication if we fall short, say by of connector care enrollment by, like, I don't know, let's say $10,000, like 10,000 members?
Thank you, Nancy. And you asked that question of me on a different day, and I meant to speak to it. So we have, Edith has prepared a scenario that's a little bit more conservative than the one that we're officially projecting here. I think it's about 7% less. And the impact on the admin budget would be it would have an unfavorable impact of about $1.5 million.
Right. And obviously if on the upside, because
yes,
that will help the budget. So, okay. Yes. Thank you.
Thank you. I see, sorry, I'm not sure who's first, Eric or Rena.
Rena, go ahead.
Carrie, I think the follow-up to that response, though, is if you or Trish could speak to the flexibility and the variability in the costs, so that if membership does come in lower and we see that, there's certain expenses we will not incur that are anticipated right now, correct?
That's right.
Yeah, there's some fixed expenses and some marginal expenses, presumably.
Exactly.
Yeah.
Exactly.
Right. That's exactly right. Again, most of our vendors, most of the payments are based on a per member per month basis. There are some additional payments that are fixed, but most of that is variable.
Thanks.
Eric? Oh, am I
Yes.
mute? Sorry. Okay.
So as is the case in most budgets, it's the same story throughout the line items, same theme. So it's the redetermination driving most of this. I'm just looking like the appeals program is small dollars, but that's got to be because you have more people and personnel and fringe at 32 and IT facility administrative wellness, I assume at plus 32, that's also related to just supporting all the additional work. And is the inference that levels off or goes down in following years, or is that sort of built up and that's gonna keep going at that level?
So with respect, I'll start with personnel first. We have accounted for the mobile outreach team here, which is about 800,000 or so. And then there's another, let's see, I think it's about 600,000 that are a cost associated with employee benefits. And then we have reflected here some additional or an expansion in operations and executive and project management support.
And that's expected to continue going following 2024?
The latter, yes. The mobile outreach team, I think, is still in question, but my understanding is for the other additional resources, those are expected to continue. And then, sorry, I can answer your other question regarding IT and facility and admin. Part of that is because we're accounting for our leases in a different way, GASB 87. But IT facility admin, there's a lot of movement in there. We have to fund small business wellness subsidies because they kind of, they flow through, they're paid for by the programmatic budget, but because they flow through our admin, we have to account for them here. So we're expecting more there. These are very minor things, but we're budgeting more for recruitment as we try and, with staffing. And then there's a couple other small things, I think software. But I think that explains most of that IT facility line item. And I just want to make sure that I answered all your questions, Eric.
Thank you.
Thank you.
Any other questions? Okay, I'm ready to call for a vote for this. First I need a motion, which I'll offer, and a second.
So moved.
Thank you, Michael, for finding the mute button.
I'll second.
Okay, thanks. I think it's time for Kathy to do a roll call vote.
Okay. Rebecca,
Yes.
Michael,
Yes.
Eric,
Yes.
Secretary,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes.
Thank you.
Okay, it's a vote. The motion carries. I think we have one more item, which is we need this does not require a vote, but it's a presentation on final minimum credible coverage regulation amendments. Oh, it does require a vote, sorry. And this presentation will be by Kayla Sherry.
Thank you. Thank you, Secretary. Good morning, everyone.
Morning.
Okay, I'm just trying to advance the slides. There we go. Okay, this one is brief, I promise. So today I will be reviewing final recommendations for minimum creditable coverage regulation amendments. In May 2023, the Health Connector Board voted to pursue proposed amendments to minimum creditable coverage regulations to specify that no cost, high value preventive services must be included in coverage that residents have to enroll in to avoid paying a tax penalty. Today, staff seek a board vote on final recommended amendments to MCC regulations. This amendment preserves coverage standards in the Massachusetts market today, despite a federal court ruling from the Northern District of Texas. This presentation will cover a brief update on the legal challenge against the ACA's preventive services mandate, a review of proposed amendments, a summary of public comments and final recommendations, and finally, we will be asking the board for a vote. Okay, so I'll begin here just by providing a review and update of the case. So as we reviewed in May, Braidwood, a recent U.S. District Court ruling, placed limitations on the ability of the federal government to enforce the Affordable Care Act's requirement that health plans cover a broad range of preventive services without cost sharing. The ruling determined that any recommendations made after 2010 were not enforceable, which would allow insurers and plan sponsors to remove coverage or charge cost sharing for these services. Examples of preventive services recommended by the task force after 2010 include lung and skin cancer screenings, PrEP for HIV prevention, statins to lower cholesterol, and medications to reduce breast cancer. There have been a couple of updates on the case since our May board meeting. Most recently, a Fifth Circuit panel heard oral arguments in June, and on June 13th, the court issued an order allowing the Preventive Services Task Force recommendations and the corresponding coverage mandate to remain in effect while the appellate court decides the case. So the state pauses the effect of the lower court's ruling that threatens access to recommended preventive services without cost sharing as required under the ACA. And here I'll just provide a quick review of our current state and proposed changes. In order to avoid facing a tax penalty, Massachusetts residents already must enroll in a health plan that includes coverage of all federally defined preventive health services, including those impacted by the Braidwood decision, without imposing a deductible. Under current regulations, a resident's coverage can be considered MCC, even if forms of cost sharing other than deductibles are present, like copays or co-insurance. In May, Health Connector staff recommended finalizing proposed amendments to MCC regulations to prohibit any cost sharing beyond just deductibles for all preventive services, and to replace the word preventive with the defined term preventive health services as a clarifying edit. Here we go. Okay. So the Health Connector accepted comments on the draft MCC regulations from May 25th to June 23rd, including in writing and in a public hearing on June 22nd. We received written comments or testimony from 2 stakeholders in total, Healthcare for All and Blue Cross Blue Shield of Massachusetts. Both voiced strong support for the proposed amendments to MCC regulations. Since we only received supportive comments, Health Connector staff are recommending that the board approve the draft amendments to MCC regulations as proposed. Staff also recommend making MCC regulation amendments effective for January 1st, 2024, in order to align with the tax year and to generally be consistent with the Health Connector's approach to individual mandate policymaking. And then here you can just see a timeline of the regulatory process. So if the board does vote to approve the final recommendations today, we will then file the final regulations in December for January 1, 2024 effective date. Okay, and then just ask for the vote here. And I see a question.
It's really a comment, Kayla. Is it correct to say that this is the snippet for this is the connector response to the Braidwood decision?
Yep.
Yes.
That's right.
Okay.
Which hasn't actually been fully promulgated, right? Has it?
The decision has been stayed. So
yeah,
as of June 13th, I believe, that was the latest, and we don't expect the decision to go into effect anytime soon. So yeah.
If I understand correctly, then if the decision got overturned, this would then just be redundant. There wouldn't be any problem.
Yes,
that's right.
Right.
I think, I'm not a lawyer.
Yeah. And if I understand correctly, there's an appendix at the end of the presentation. What this basically is saying is that set of services at the end of in the appendix would have to be cut. Yeah, that set of services, those would have to be covered with no cost sharing, because those are the ones that we caught up in the Braidwood thing. And then what I just missed in the wording is if there was a future U.S. Preventive Services Task Force recommendation that's not on this list, I think the wording is such that that would also be covered under the new rule as automatic. Right. So we're not just fixing the gap in the ones that were caught up here to date, but we're fixing any gap going forward. That's my sense of what this is.
Yes, absolutely. And I just want to clarify too that this list is just sort of some major additions and revisions after 2010 that are impacted. So there's even other additional preventive services that aren't even shown here. But these are sort of the big ones.
Yeah. So,
Michael, I wonder though if to your point, should we modify the vote to say, if you can go to the vote page,
sure,
to reflect that well, no, that doesn't say as described, or I was thinking current and future.
Yeah, so that's why the vote is something that could only be loved by a lawyer. But the the actual thing we're voting on in layman's terms is to maintain
preventive service.
Braidwood in the Commonwealth.
Yeah,
At
yeah,
least for the connector, at least for the
Yeah.
connector.
yeah.
I'm also not
I
a
think it's-
lawyer, but I would imagine that we issued a set of draft regulations. We had a hearing. Now we're adopting those. If what we're saying is we want to modify in some way the draft regulations, then I would think we'd have to do that and have a hearing again.
Oh, would we?
Yeah, yes, we would,
That is true.
we would need to start over.
Okay. So let's not snatch defeat from the jaws of victory. Let's vote this, and we have to vote another one. We'll vote unless anyone
No, I agree, but also this applies because it's minimally credible coverage. This actually applies for the Commonwealth writ large.
Yeah. Yeah.
Yes, it applies to Blue Cross, is my understanding.
It
Applies to, right?
It applies to MCC. So
Yeah,
in order
exactly.
for you to meet the requirements of the individual mandate, your coverage has to comply with all the MCC requirements.
Right,
including-
exactly. So this is, all right.
Indirectly.
Sorry for,
You know, maybe Audrey, we could have the minutes reflect this discussion so
Sure.
that the intent of the board is clear for the record. Just, you know, administrations change, presidents change. We should probably be on the record.
Sure. Of course.
Nancy, your hand's up.
I have a different just comment I wanted to make, which I wanted reflected in the minutes, that that I am surprised and disappointed that none of the other health plans expressed support for this set of amendments, particularly with all the public statements they've been making in recent months about their commitment to addressing health inequities. And we know access to preventive services and the health consequences of that, of not getting preventive care, are an area where here and everywhere else result in inequities. So I'm surprised by that, but commend Healthcare for All and Blue Cross for going on the record.
We'll get that reflected as well. Okay, Nancy, why don't you move this for us?
I move the motion.
And we need a second.
seconded.
Thank you. Okay, Kathy.
Okay, Rebecca,
Yes.
Michael,
Yes.
Eric,
Yes.
Secretary,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes.
Thank you.
Thanks, Kathy. Okay, the motion carries. And I think we also need, unless there's additional comments or questions, wow, 10 minutes to spare. I didn't think I was going to make it. I'm going to give everyone back the gift of time unless Audrey has any closing comments.
Not at all. Thank you so much to the board and to staff.
Great. I'll echo that and ask for a motion to adjourn.
So moved.
Thank you. Eric, it was always a hearty endorsement for that. Kathy, you're.
I'm on. Okay, Rebecca,
Yes.
Michael,
Yes.
Eric,
Yes.
Secretary,
Yes.
Nancy.
Yes, with thanks to all the staff for all the work that was reflected in today's meeting, which is a lot.
Yes,
Okay.
I agree. Thanks.
Matt,
Yes.
Rena.
Yes.
Okay, that's it. Thank you, everyone.
All right, terrific. The motion carries and we will see you at our next meeting, which is in September, right, Audrey?
Yes, unless we need to have an earlier one if anything happens in the legislature, but otherwise we would plan to see you in September.
Terrific. And thanks to everybody for their hard work, and enjoy the few days of summer that we have ahead of us. And thanks to everyone. Have a wonderful day.